Imagine going in for a routine surgery to fix a pelvic issue, only to have the synthetic mesh meant to heal you just, well, begin tearing right through your own tissue.
Yeah, it's a terrifying thought.
It really is. And for up to 25% of women undergoing certain pelvic procedures, this isn't just like a worst-case scenario. It's a painful, life-altering reality.
Absolutely.
But what is the difference between a successful implant and an absolute surgical disaster? Wasn't the plastic mesh itself, but a simple localized hormone cream.
Right, and it's one of the most compelling biological mysteries we've encountered in our sources, because when rigid engineering meets the living, the constantly shifting environment of the human body, the rules just change entirely.
Completely. And for you, our listener, we're going to unpack exactly why that happens. Welcome to today's deep dive.
We have a lot of ground to cover today.
We really do. We are taking a massive stack of complex sources. We've got clinical guidelines from organizations like Stegros and the Royal College of Obstetricians and Gynecologists.
Very dense stuff.
Oh, highly detailed surgical studies. And most importantly, we have vital, really passionate evidence from patient advocacy groups like Sling the Mesh.
Which is so important for the real-world context.
Exactly. So we're taking all of this and zooming in on one incredibly specific, fascinating biological question. Does the use of vaginally delivered estrogen affect the integrity, positioning, or safety of pelvic mesh implants?
And to really answer that, we have to recognize a fundamental truth right out of the gate. Estrogen does not chemically alter a piece of plastic.
Right, it's just plastic.
Exactly. Polypropylene mesh is inert. But estrogen profoundly alters the living biological environment holding that plastic.
The tissue itself.
Yes. Today, we're going to see how manipulating that environment acts as a preventive shield, a conservative rescue treatment, and surprisingly, a highly dangerous variable if it's used at the wrong time.
Okay, so let's start with the root of the problem. Millions of women undergo surgeries for pelvic organ prolapse, or POP, and stress urinary incontinence, SUI.
Right, very common procedures.
And the standard procedure for a long time involved using synthetic mesh to act like a hammock, basically supporting those failing tissues. But the patient advocacy groups in our sources, they highlight a deeply troubling history with these implants.
The human cost has been staggering, honestly.
We're talking about severe complications, chronic, debilitating nerve pain, the inability to sit comfortably, organ perforation, and the terror of multiple highly invasive revision surgeries.
And the medical science behind that suffering usually comes down to one primary complication. Historically, doctors called it erosion.
Right, but our sources note a very deliberate shift in the terminology there.
They do, yeah. It's no longer called erosion because the plastic itself isn't, eroding or degrading into the tissue.
Right, it's not like a battery leaking acid or something. The medical community now calls it exposure or extrusion.
Which is a much more accurate description of what's happening.
Because it's a failure of the biological tissue holding the mesh. Like the suture line is disrupted or local inflammation takes over, and the flesh simply gives way, leaving that rough plastic exposed.
And the data reveals just how frequently this happens. While stress urinary incontinence sling complication rates are somewhat lower, pelvic organ prolapse mesh complication rates can hit 15 to 25%.
Wow, 25%.
Yeah. And the exposure rates specifically range anywhere from 7.3% to 21%, depending on the study you look at.
To put that into perspective, it sounds like putting a rigid, heavy-duty tent pole against a worn-out, fragile canvas tent.
That's a great analogy.
Eventually, no matter how perfectly engineered the pole is, the tension and friction are going to cause it to poke right through the canvas.
Exactly.
But here is the question that jumps out. Why does the canvas wear out in some patients and, completely hold up in others? Why does the tissue fail?
Well, if we look at the cellular level, we find two massive documented risk factors for mesh exposure: advanced age and estrogen deficiency.
Estrogen deficiency.
Right. Clinically, this is often referred to as vaginal atrophy. Postmenopausal women with genital prolapse just have a vastly different biological landscape than women with normal, healthy estrogen levels.
What does that actually look like under a microscope? Is the tissue literally starving?
That is a very accurate way to describe it, actually. Without estrogen, the tissue lacks elasticity, thickness, and really crucial blood flow.
Because the blood vessels just aren't there.
Exactly. Think about the structure of the vaginal wall. You have the surface layer, the epithelium, and beneath that, the lamina propria, which normally has a rich, dense vascular network.
Yeah.
Estrogen is basically the signal that tells the body to maintain those blood vessels. When estrogen drops, the blood vessels retreat.
So when a surgeon places a piece of synthetic plastic into that environment, the body goes into high gear, trying to heal around it, but it simply doesn't have the biological supply chain to deliver the material.
It just can't keep up.
The canvas is too thin, and there are no supply lines to patch it.
Which leads researchers to a massive, really game-changing hypothesis. If a lack of estrogen causes the tissue canvas to fail, could we proactively introduce estrogen before the mesh is surgically implanted to literally rebuild the tissue?
So do we just fix the canvas before we pitch the tent?
Precisely.
This is where our sources deliver a massive aha moment. There's a fascinating 2014 study by Good et al. That tested this exact theory.
Yes, a really landmark paper.
They took postmenopausal women who were planning to undergo surgical repair for pelvic organ prolapse, and they prescribed them a localized topical estrogen cream for just 6 weeks prior to the surgery.
Just a month and a half. And the biopsies taken during the operation revealed changes that are, well, they're nothing short of staggering.
What kind of changes?
First, let's look at the anatomy. The estrogen increased the thickness of the vaginal wall's epithelial layer and the deeper muscularis layer by 1.8 to 2.7 times.
Wait, let's make sure we visualize that for our listener.
Right.
The epithelial layer is the surface, right? Think of it like the tough outer tread of a tire.
Good way to put it.
And the muscularis is the deeper structural layer, the internal steel belts of the tire. And a simple topical cream made both of those layers almost 3 times thicker.
It did. But the real magic happened with the proteins inside those layers. The mature collagen in that tissue, specifically type Ia protein, increased 9-fold.
9-fold? That's insane.
It is, and type Ia is the incredibly strong structural collagen that acts like the biological rebar of the human body.
A 9-fold increase in structural collagen. That is massive.
And at the exact same time, there was a dramatic drop in tissue-degrading enzymes, specifically one called MMP9.
Matrix metalloproteinase 9.
Right. In a healthy body, MMP9 is used for remodeling tissue, essentially clearing out old cells. But in estrogen-deficient tissue, it runs rampant, just breaking down structural integrity.
So it's basically tearing down the house.
Exactly. The 6-week estrogen treatment caused MMP9 levels to plummet 6-fold.
I love this because it explains the how, not just the what. The estrogen is essentially firing the demolition crew, the MMP9 enzymes, that were breaking down the tissue.
Right.
And simultaneously, it's hiring a massive construction crew to pump out structural collagen.
Which directly answers our core question about the safety and positioning of pelvic mesh implants.
Because it's changing the environment.
Exactly. The estrogen is not altering the polypropylene mesh, it's entirely changing the biological foundation that the surgeon is about to anchor that mesh into.
It's like reinforcing the soil, enriching it, and making it incredibly dense before you pour the concrete foundation of a house.
That's spot on.
The house isn't changing, but its chances of shifting or cracking plummet because the ground is solid.
Furthermore, this well-estrogenized tissue has vastly superior blood flow. So when the surgeon makes the incision and places the implant, the tissue has the immediate biological resources to respond to that trauma.
It's ready for the shock.
Right, which drastically diminishes the risk of the mesh slipping or becoming exposed during the healing process.
Okay, so priming the tissue before surgery makes perfect logical sense. But let's look at the millions of women who already have these implants.
Right, the post-op reality.
Say a patient had the surgery 5 years ago. Now they're experiencing that dreaded extrusion complication we talked about earlier. The rigid plastic is poking through the tissue. If they go to their doctor, what happens next?
This is where we turn to the clinical guidelines, specifically the NICE guidelines from the UK regarding the management of mesh complications.
Okay, what do they say?
Their recommendation for a patient presenting with a small area of exposed mesh is not immediate surgical removal.
Oh, really?
The first line, conservative treatment, is actually prescribing topical vaginal estrogen cream for at least 3 months.
Hold on, I really have to push back on this. If a piece of hard plastic is physically poking through the skin, causing pain, how on earth does a hormone cream fix that?
I know, it sounds counterintuitive. The goal is to command the surrounding tissue to mount a rescue mission.
A biological rescue mission. Okay, break that down for me.
When the localized estrogen is applied, it rejuvenates the surrounding healthy tissue at the border of the exposure. It binds to cellular receptors and prompts profound angiogenesis.
Angiogenesis, the rapid formation of new blood vessels.
Exactly. It floods the area with nutrients and signals the cells to multiply, creeping forward and eventually growing back over the plastic, sealing the tiny defect entirely.
Wow. It acts like a biological sealant. It literally commands the body to grow a fresh layer of canvas over the exposed temple.
That's exactly what's happening.
And if that works, the implications for the patient are life-altering, right?
Beyond life-altering, they avoid a highly complex mesh removal surgery. And the data from our patient advocacy sources paints a really grim picture of what those removal surgeries actually entail.
It's not a simple procedure.
Not at all. Over time, synthetic mesh can shrink inside the body by up to 53%.
Over 50%, so it tightens like a vice inside the pelvic floor.
It tightens, it becomes incredibly brittle, and the pores of the mesh collapse. And as it does this, it becomes deeply entangled in surrounding tissues, nerves, and organs like the bladder or the bowel.
That sounds horrific to try and remove.
It is. Scraping it off the bone or excising it out of the flesh is fraught with the risk of permanent, severe nerve damage. Removing these devices is not like sliding a battery out of a flashlight. It's a painstaking excavation of deeply embedded foreign material.
So if a simple, localized cream can command the tissue to heal over the plastic and save a patient from the trauma of an excavation surgery, that is a monumental win.
A huge win.
But there has to be a physical limit to this. I mean, the tissue can't bridge a massive gap just because you give it estrogen.
You're absolutely right. There is a very strict limitation outlined in the guidelines. This estrogen rescue therapy is clinically proven to work only for mesh exposures smaller than 1 square centimeter.
1 square centimeter. That is incredibly small. That's roughly the size of a standard button on a dress shirt.
Right. And for any exposure measuring 1 square centimeter or larger, the guidelines are clear. Estrogen cream is simply not effective.
The gap is just too big.
The biological gap is simply too wide for the migrating cells to bridge on their own without a scaffold. In those larger cases, outpatient surgical trimming of the exposed plastic or full surgical removal is absolutely required.
That makes sense.
But for those microexposures, estrogen serves as a powerful, non-invasive first step that can, spare a patient from the operating table.
So if we look at the timeline we've built so far, estrogen is miraculous before surgery, building up the tissue layers, and it's a fantastic rescue treatment for minor exposures years later.
Correct.
So if I'm a surgeon and I just placed a brand new mesh implant into a patient and stitched them up, well, my first instinct is to prescribe estrogen immediately.
Sure.
Why wouldn't I want to flood the area with collagen and blood flow right as they wake up to ensure perfect, fast healing? Is that standard practice?
It is the most logical assumption you could make. But the human body loves to defy our logic. A 2017 study by Ripperda et al. Investigated this exact scenario, acute, immediate postoperative vaginal estrogen. And what the data reveals is a fascinating paradox.
What did they find?
The study refers to acute postoperative estrogen as a profound danger, one that actually jeopardizes the implant.
Wait, really? We just spent the last 10 minutes talking about how it builds collagen and blood vessels and, hires the biological construction crew. How can it possibly be dangerous to use it right after surgery?
To understand why, we have to dive into the actual timeline of wound healing. Healing isn't just one continuous process. It happens in distinct, necessary phases.
Okay, walk me through it.
Immediately after a surgical injury, the body enters the hemostasis and inflammation phase. In this critical early window, the body actually needs a significant amount of inflammation.
Needs it.
Yes. Inflammation provides temporary stiffness and lays down the initial rigid scar tissue matrix. That inflammatory stiffness is the temporary scaffolding that holds the synthetic mesh in place.
So inflammation isn't always the bad guy.
Yeah.
In the days right after surgery, inflammation is the biological glue.
Precisely. But here is the twist. When you administer estrogen immediately after a surgical injury, it acts on the different layers of the vaginal wall in conflicting ways.
Conflicting how?
Well, it does wonders for the surface layer. the epithelium. It causes marked cellular proliferation, rapidly thickening the surface skin and creating a strong, beautiful barrier against outside infection.
Okay, so the surface looks perfectly healed. What is happening deeper down?
Deeper down, in the stromal layer, the structural foundation where the mesh is actually anchored, estrogen acts as a potent anti-inflammatory.
Oh, I see where this is going.
Yeah. By suppressing that necessary early inflammation, it prematurely shuts down the scaffolding phase. The researchers found that immediate postoperative estrogen decreased tissue stiffness and significantly lowered the collagen content in that deep compartment during the acute healing phase.
Let me try a different analogy here.
Yeah.
It sounds like putting a cast on a broken arm, but making the cast out of soft memory foam.
That's exactly it.
It feels incredibly soothing on the skin, it looks great on the surface, but it completely fails to provide the rigid inflammatory scaffolding the deep bone needs to actually set and fuse.
That captures the biological reality perfectly. By reducing that necessary early stiffness with estrogen, the deep tissue becomes soft and pliable far too early.
And the mesh needs it to be firm.
The heavy synthetic mesh needs a firm matrix to integrate into during those first critical weeks. If the deep tissue is softened by the estrogen, the mesh might shift out of position, fold over on itself, or fail to integrate into the surrounding tissue altogether.
Which completely sabotages the positioning and safety of the implant. You end up with a perfectly healed surface layer of skin covering a deeply unstable piece of hardware that is just, well, primed to fail.
Which is why timing is the single most critical variable when it comes to hormone therapy and pelvic mesh. It demands an incredible level of nuance from clinicians.
It's a massive balancing act.
You are constantly balancing the patient's inflammatory response, the timing of their collagen synthesis, and the integrity of their epithelial barrier. Estrogen is not just a general healing potion. It is a highly specific biological signal that must be deployed at the exact right moment.
This completely upends how we traditionally think about surgery.
Mm.
I mean, we're so used to the mechanical mindset, you fix the part, you close the incision, and the job is done. But you can't treat the human body like a simple machine.
No, you really cannot. And this synthesis of sources highlights the sheer complexity of the environment we're operating in.
Let's bring this all together for you, our listener, who joined us to cut through the noise. We started this deep dive looking at a massive stack of complex clinical guidelines, surgical controversies, and the deeply human stakes highlighted by patient advocacy groups.
We covered a lot.
We asked if localized estrogen could determine the success or failure of a pelvic mesh implant. And what we found is that vaginally delivered estrogen doesn't alter a single molecule of the physical plastic. Instead, it is the ultimate puppet master of the cellular environment.
It commands the environment, for better or worse, depending on when it's introduced.
Exactly. It's a powerful pre-surgical shield that thickens the vaginal walls, starves the demolition enzymes, and boosts the collagen construction crew.
Yes.
And it's a brilliant, non-invasive rescue treatment that can command the body to seal over tiny exposures under 1 square centimeter, saving patients from harrowing excavation surgeries.
But as we just explored, it is also a highly volatile biological variable if used immediately post-surgery.
Right, acting as an anti-inflammatory that softens the deep tissue and sabotages the critical scaffolding phase where the mesh needs to anchor.
Which brings up a really important question about the future of all this.
It does. And as we look to the future, this entire conversation raises one final vital question based on our sources. For decades, the medical engineering field has spent millions of dollars trying to perfect the physical weave, the weight, and the pore size of synthetic plastic meshes.
Leaking the plastic.
Yeah, we've treated pelvic prolapse like a purely engineering problem. But if the ultimate safety, positioning, and long-term viability of these implants relies so heavily on the hormonal health, the blood flow, and the collagen production of the patient's local tissue, are we treating a biological problem with the wrong tool?
It is the most important question the field is facing right now. And some of the forward-thinking researchers in our sources are already exploring alternatives to synthetic plastic.
What are they looking at?
They're developing extracellular matrix bioscaffolds.
Living tissue instead of inert plastic.
Yes. Instead of placing a rigid foreign barrier into the body and hoping the tissue learns to live with it, they're using regenerative biological tissues.
That sounds incredible.
These bioscaffolds are designed to actively communicate with the body's cells, responding to hormonal signals naturally, integrating and eventually dissolving as the patient's own native tissue replaces it.
It brings us right back to our opening thought. If the human body isn't a bridge, Maybe we shouldn't be using steel girders to fix it. It leaves us wondering, will the future of pelvic surgery abandon plastic mesh altogether in favor of implants that are designed to work with your hormones, rather than constantly fighting against them?
Moving from mechanics to true biology is a profound shift in how we view surgical repair, and it's a shift that couldn't come soon enough for the patients relying on these procedures.
It truly is. Thank you so much for joining us on this deep dive today. Keep asking those big, complicated questions, keep looking past the surface level of the medical science you encounter, and keep exploring the fascinating, sometimes contradictory intersections of medicine and biology on your own. Until next time.